Yeah, so I think we can get started. So a warm welcome and to EASL Congress and to our first press conference. My name is Thomas Berg. I'm the Secretary General of EASL, and I will explain you in a minute a bit more and talk about what EASL is. First of all, I want to apologize that we are a bit late starting here. We're overrunning a little bit our opening ceremony, but I think we will have enough time, and this is one of the most important things here today, that we give you a kind of a broad and global perspective of what we are doing here. What does it mean for us that we have our annual meeting here 2023 in Vienna as the annual EASL Congress? What are the main expectations, what we already did in order also to inform the community about liver health and liver disease. So before I come to also some housekeepings, and I realize that we do not only have here on-site attendance, but there are also journalists being remotely connected, and they can ask questions. I will tell you later. Perhaps some information about EASL. EASL means the European Association for the Study of the Liver, was founded in 1966, and we now have a member base of more than 5,000 people. But we are, of course, our area of main interest from a geographical point of view, of course, is Europe. But, of course, our mission is also global. We are an international congress. We have delegates here from more than 100 countries throughout the world. So it's really international, with large community also coming from the US, nearly 20% coming from Asian Pacific region, and around 50–60%, of course, here of the European countries. Having this congress, it's for us a very important time also to reconsider what we did, to show where the research is going. And this is highlighted by nearly 2,000 abstracts that have been selected here as the best of the best to be presented in a kind of an order. The most important one that could be game changer being in the general sessions. Then we have parallel sessions, and then we have the poster presentation and also certain poster awards for the most intriguing posters we will show. So it gives us really a good, to set the stage where we are and where we can develop from here. And every of these congresses is a major step forward also in our clinical management for patients with liver disease. So why it's so important and why there's an organization only studying liver disease? Well, you know, this happens for all the other organs, but an overarching term, and we want to discuss here also with you, and where we need also an audience, a broader audience, also in the population and being transported by the media, is the topic of prevention. And we have nearly 300,000 people dying yearly in Europe because of a liver disease. And I'm not lying when I'm saying most of them could have been prevented by early detection, early treatment. This means early prevention. But the issue is that the liver doesn't hurt. So when it comes to symptoms for a patient, then you are in a stage of the disease where it's too late. You know, then we call it a cirrhosis. This is scarring of the liver, the organ is shrunken, and you have all these awful complaints the patient have with water in the body. You have brain dysfunction, even heart and kidney can be affected, and of course a huge risk of developing liver cancer. And liver cancer is one of the very, very few cancers where we see a constantly rise in the incidence rates in the number of cancer. And this is really concerning. And I think now for the first time also the European Commission realized that this is something they have to do something against it, because as I mentioned, liver cancer can be prevented. It's completely different from all the other cancers. You know, whether you suffer from a prostate, a breast cancer, a colorectal cancer, this can happen in a healthy colon. Liver cancer will only develop in 80–90% if you have a liver disease. And here we come to a next important point. So why liver cancer and liver diseases are on the rise? And this has something to do with the increase in the rate of fatty liver disease we are seeing in our community, with 20, 30, up to 40% in some regions suffer from fatty liver, and fatty liver will be perhaps the most important driver or cause for liver cancer in the future. And I think we will touch on this later on when I will like to introduce our faculty and our specialists here. And what I want to give you as an information from the beginning is what we also did in the beginning of this annual Congress the last 2 days, together with the help of patient organizations, but also with the Ministry of Education here in Vienna, with the National Society of the Austrian Society of Gastroenterology and Hepatology. We involved them to go into the community here in Vienna and to teach them in the way to talk about liver health and liver disease. So we did it that we visited a high school and we talked to children about liver health and what can damage the liver, if you like. We had a meeting in the town hall with most stakeholders where we talked about, again, liver health and disease with many stakeholders. Also, some of them are present, attending here this meeting. And if you like, and you can, if you would like to have this experience outside, we have a truck where Vienna population can check their livers. So there's a quite simple machine. It's a bit like an ultrasound. We call it FibroScan. So it looks, so you can quite simple in a few minutes without any damaging, or it's not inconvenient to do this, really like an ultrasound. You can check for the how healthy your liver is, or whether there's already some scarring or not. And you can also get for free an hepatitis C testing. So if you would like to have this experience, you will find the truck outside. Well, before we come to the talks and then to the discussion, and as I mentioned, this is the most important thing that we address your interest, your questions around what we are doing here. I would like to give you some housekeepings. So this official opening press conference is being broadcasted live on the conference platform and will be recorded and made available to EASL YouTube page shortly after it has ended. Today we will be hearing brief remarks from all our speakers here on the podium, and then I will open it for questions from our media representatives, both on-site and online. And those media physically in the room, we have a roving microphone, so please indicate your media outlet and who you would like to direct your question to. And we will then try to answer it as best as possible. And to the journalist watching online, type in your question. So I have here a pad so that we can see your question and can answer it from here. And please keep your questions brief, that we can try to answer as many of your questions as possible. So without further ado, I would like to introduce the first speaker. It's Professor Thomas Reiberger. He's a professor of gastroenterology and hepatology at the Vienna General Hospital at the Medical University in Vienna. So you will give a brief outlook about the state of liver health here in Austria. Please, Thomas.
Yeah, absolutely. Thank you for having me here, Professor Berg. I'm currently the working group leader hepatology of the Austrian Gastrointestinal and Liver National Society. And we also think that EASL coming to Vienna is a very important catalyzer for the activities we are anyway already doing. And Professor Berg nicely summarized the most important threats that we see in the field of liver health and also liver disease across Europe. And this is also the same for the Austrian situation. We face a situation where fatty liver disease is getting extremely prevalent, and it's particularly increasing in the young people of our society, meaning the adolescents and the school kids. And that's why I think it was particularly important to go to these primary schools and to educate the kids, because liver disease is preventable, as we heard, and with a slogan such as "Love Your Liver," I think it's so important to transport this message. I think it was a success, and it will have legacy. So we are actually on the national level already planning to have these activities also on a more global scale and regular basis across the country. So this is about educating people and raising awareness. But we have also learned that there is sometimes late diagnosis, and liver cancer and also cirrhosis can occur later. And here I really want to mention that on a national level, we have very functional liver transplant programs. And these are actually only working because so many people are involved in sustaining this. And that's why we can save lives from those patients who are affected in the most severe way. But also an aspect that I don't want to miss here in my message is there are rare diseases. While we know fatty liver disease from metabolic diseases and alcohol abuse is the most prevalent one, and viral hepatitis is something that I'm going to address very quickly also. There is rare diseases that are genetically caused, but there are also from rare autoimmune diseases that can be effectively treated, but we need to identify them. And this is also what we are working on a national level, to identify those patients with autoimmune disease, with the primary biliary cholangitis, primary sclerosing cholangitis, because these sometimes progress very quickly. And finally, in regards to viral hepatitis, also the National Society in Austria is dedicated to meet the WHO goal of elimination of viral hepatitis. And in this regard, we have very active programs for Hep C elimination that target vulnerable populations like the homeless and the people who inject drugs, but also working in the field of hepatitis D, the most aggressive form of viral hepatitis. So thank you, EASL, again for coming to Vienna. We are very happy to have you here, and we will use this event as a catalyzer for all our national activities. Thank you very much.
Yeah, thank you, Thomas. And you know, I mentioned, and Thomas also mentioned, that diseases are preventable, there are programs, and this is all, of course, related to policy and public health change. So because why we are not successful, and I mentioned that, yeah, if it's diagnosed, we can treat it. So where's the issue here, and how to approach to the situation where you can, in a way, find the patients being at risk. And of course, here we have to liaise also with family doctors, with a broader context, and we need the help of the policymakers, because quite often it ends up also where the resources are going to. But you may imagine that it is already difficult to establish this healthcare change and the management change from, let's say, to have a focus on the end-stage disease, you know, if the patient comes with complaints, and so you treat symptoms, towards management change towards prevention. But you could imagine if it's already difficult here in Austria, in Germany, throughout Europe, how difficult it could be to achieve these public health goals in a situation where confronted with a war. And therefore, we are quite happy and grateful to have Tetiana Deshko here with us. And she is the director of the Alliance of Policy and Public Health in the Ukraine, and has a huge experience also with elimination programs. So could you give us an insight and overview about the situation in Ukraine and how to try to manage to be successful with the projects? And we know that Ukraine has one of the highest rates, I think, of viral hepatitis, especially hepatitis C, throughout the world. Yes. So, Tetiana, over to you.
Yes, thank you. Thank you very much. I'm Tetiana Deshko. I'm Director of International Programs, Alliance for Public Health, a Ukraine-based NGO. We are normally engaged on responding to HIV, hepatitis, tuberculosis with key populations, prevention, diagnostics, treatment programs, linkage to care, but now we do very different things. After the 24th of February, our work changed completely when Russia started bombing Ukraine. With the vehicles that we used for diagnostics, for reaching out with screening tests, we started to evacuate people from the front line. We started to deliver medications to people who could not access them anymore. We started to organize shelters, and now we're also running shelters for disabled people because there are many people now with disabilities. We were preparing for a cold winter. We were buying electric heaters, but then our electricity was destroyed, and we were buying wood to keep our communities and to keep our patients warm. It's been, we had to be inventive too, taking the incredible movement of people within Ukraine and outside of Ukraine. It's also a big movement of patients. With about 15 million people, it's about 30% of the country's population. They have moved within or outside of Ukraine. We try to ensure that the patients are not lost to follow up. So we organized an online, it's a chat bot, but also a kind of a group of 24/7 consultants who are helping link people to their treatment for HIV, for hepatitis, for substitution therapy in the new locations where they were. We also organized online consultations by medical professionals from Ukraine who were able to support their patients wherever they appeared. With the mobile ambulances, we also go to the front, almost to the front lines, and sometimes we are kind of in the occupied territories when we come with our minivans, with doctors, nurses, social workers. First you see no one there, and then kind of after 10 minutes people start coming out from the undergrounds of their houses, and well, they're often elderly people but also young people. They say that they haven't seen any medical worker for the last half a year or so. So they come with very basic needs. We bring these basic needs. We address humanitarian needs. We also do hepatitis C rapid testing. We deliver medications to health facilities, and we deliver patients to the closest health facilities where they can receive them. And in Ukraine, even before the war, the situation was really alarming with hepatitis. So Ukraine has estimated 5% of adult population living with hepatitis C. It's 1.3 million people. So it's a massive population. But unfortunately, only 100% are recorded with hepatitis C. So actually, almost like 1 in 10 knows that he or she has hepatitis. So actually, the program had to be scaled as much as possible, but it's very difficult in the war conditions. The government used to procure medications and treating about 16 to 18,000 patients with hepatitis C every year. Now it has reduced to about 12,000 patients in 2022. It is largely because there are not enough medications to treat people, and there's just too many structural barriers. Populations are moving across the country. Some of the facilities are not available anymore. Like 1 in 10 health facilities in Ukraine has been either destroyed or damaged by Russian shelling. We used to have hepatitis treatment in about 230 medical hospitals offering treatment across Ukraine. Now it's around 80. So there are not enough medications, and very few can actually conduct this work. But nevertheless, it was a challenge that we have taken. So we were able to mobilize international resource to procure more medications, to actually have more screening, testing, and treatment options on site. So treatment program did not stop, and we were able to follow up with the patients wherever they were. We as Alliance, we have picked up the very difficult group of patients. They are people who inject drugs, that are co-infected with tuberculosis and with HIV. We provided treatment to 2,000 people last year, and treatment success was achieved in 96% of patients. So we arranged the necessary social support, the necessary medical support, online support, handling the prescriptions and other tests through WhatsApp, but still being able to help the patient wherever possible. So there are new challenges occurring. Of course, on the battlefield, there is a lot of blood contact for the military people. We do not know how massive the situation or how challenging it is. In numbers, we are providing some of the rapid tests to the military personnel, and we think that this is one of the gaps that the country would soon have to address more significantly. I would like to appreciate the incredible solidarity that we as a Ukrainian civil society have observed in Ukraine. It's been a tremendous help in supporting our patients, in supporting our services, in supporting our healthcare. Those were with international donor funds, also with private funds. It's an incredible battle for all of us, and our victory will be our prize. Thank you.
Yeah, Tetiana, thank you so much, and I think you really have the admiration of everyone here in the room of what you did in really to keep the patient healthy in your country. It's really incredible, how you try to sustain this situation even under these circumstances. And this brings me also to the patient representatives and to a word called health literacy. And I think it's important. First of all, policymakers will also listen to patients, perhaps even more than to physicians. It's a kind of an experience. On the other hand, I'm quite convinced that people, and many people are not patients from the beginning, need to be their own advocates, right? And so if you have the knowledge that if you have certain, I don't want to call it risk factors, but let's say if you, with increasing age, you increase some of your weight, perhaps they are starting a bit like a diabetes is coming or so. And of course you have your regular social beer or so on. But this might be a situation where it's wise to check out for the liver. Everything is okay or not. So what is the contribution of patient representatives? I'm quite happy to introduce Josie Willemse. She is from the Executive Director of the Dutch Liver Patients International, and she's on the board of Liver Patients International. Please.
Yeah. Well, the original name of the patient organization I'm working for is the Dutch Liver Patient Association, and I'm also a board member of the Liver Patient International. Members of a patient organization are ill. That's why they became a member. They will be a member because they want more information and they want that somebody is advocate for them. And that's what we do in general. That's why our name is also Patient Advocates. And we can play a role with governments. We can put some pressure on the press, but it's never enough what we can do. And it's our patient story, or our patient stories, who send the message, because that is telling what people face in life when they have a liver disease. And that's make my job very easy, because I always say to my members, well, I'm telling your stories. But those stories are extremely impressive. And it's also important to do that here at EASL. And I think it's very good to have the knowledge, the scientific knowledge, of course, and the psychological, but also the patient stories. How does it affect people at home in their life, in their daily life? And that's extremely important because a lot of doctors don't realize that. It's not that they don't want that, but it's something you never discuss with your patients. As patient organizations, we play a role in that. And of course, the first thing is to provide people from information about their liver disease. In both organizations I attend, we do that for all liver disease, from ultra rare to not rare. And one of our focus is also awareness, because for us it's frustrating too that people don't know where their liver is, what it is, how big it is, how heavy it is, and what can happen with your liver. And when they realize, it's always too late because they have a liver disease. And that stories are coming more and more to me in my patient association, and that's really something we're really worrying about, how to solve this problem. The only thing we can do is give information and try to get people interested in the liver and in the whole liver health, because that's where it's, well, at the end, it's about, and it's about the patient. And well, so that's really a challenge to do. And well, we at patient organization, you will find them all around the world. Most of them are here. And I can only say that we are very close friends to each other. And we have a really good relationships with the doctors and the physicians and the scientists. So that's very helpful because we have also translate what here is happening, what the news here is coming, to the patients. And patients always hope for big breakthroughs. That's everybody. But we know, and also patients know, that it will be only small parts of the puzzle, but that is helping too.
Yeah, thank you. Thank you so much. I hope you can hear me. There was a feedback from the people watching remotely that I should speak into the microphone. I try to improve this, and I hope the microphone is working. Please, otherwise let me know. Well, we're coming to an more opening the field to the future. And you know all about the discussion about open AI and artificial intelligence, machine learning, and all these words you're aware of. But it's entering medicine, and we already have many presentations here at EASL Congress 2023 where they try, with the help of artificial intelligence, to improve what we are doing. And of course, you can think about and speculate about how it will help to solve some of the issues we already have discussed. And just to give you an example, the European Commission, the EU, just financed or funded a very big consortium here in Europe, many countries involved, related to patients in need of a liver transplantation. And you know, some of these patients are entering a wait list, but they are already perhaps too sick, or due to the organ allocation system, they will not get an organ, and they died while on the waiting list. It's always a catastrophe. On the other hand, some patients may be in a stage that even if they get a transplant, they may not have the wanted outcome. And they're trying, with the help of machine learning, artificial intelligence, to try to figure this out. It's funded by several millions for a European project, just to give you a heads up of what's really going on here. But we have an expert here with us, and it's Professor Vlad Ratziu. And he's based at the Institute of Cardiometabolism and Nutrition at INSERM. INSERM is a very big and research institution, governmental research institution in France, in association with the hospital Pitié-Salpêtrière and Sorbonne University in France. So over to you, Vlad. What would be your comments to artificial intelligence and the rise in presentations and so on? Very interested in your thoughts.
Thank you, Thomas. Thank you all for attending. So, yes, it seems a little bit unreal to talk about artificial intelligence given what we heard about what other people have to face in their everyday life and struggle to still maintain the health of the population. And again, all our support and congratulations for what you're able to do. And we hope that this situation, absolutely intolerable situation, will end soon. I guess you underline the challenges and also the opportunities of what artificial intelligence in a broader sense could bring to patient management. Artificial intelligence is a very vast concept. It starts being more and more present in hepatology in terms of research. Basically, I would say that what it can do, these sort of tools, which are very diverse, but they all aim to allow us to see further than what the human eye and the human brain is able to process. And you can do that and therefore discover things that are not visible to the human eye or to the human brain and the traditional computational methods. And you can do that in many different ways in medicine, but what we are concerned here specifically at this meeting, going through what is going to be presented here, is two types of artificial intelligence approaches. The first type is trying to analyze a very large set of very diverse data that we usually analyze separately one by one. So you analyze clinical biological data, you analyze data from pathology, you analyze data from molecular biology, but it's rare that you put all this together, because then you end up having a tremendous amount of data that is very difficult to process if you don't have sort of artificial intelligence tools. So the first approach is to analyze a very large quantity of very diverse data and try to uncover patterns that are distinctive of a disease, or of a risk for a disease, or for a prognostic risk that otherwise would be unnoticed with the traditional methods. So this is a very powerful tool, because it associates computing methods and also a sort of a machine learning process where you refine the diagnosis based on iterations of the data that are already available. So this is a sophistication of methods we already have, but that allow us to understand that. The output of this is to try to determine, and that's what Thomas Berg said, try to determine a little bit better who is at risk of liver disease, try to predict the future in these patients, and who will develop complications, and therefore, ultimately, to develop a medicine that is much more individual based, so what we call precision medicine, what we call individualized treatment. Because people are very diverse and they don't evolve in the same way, even though they're exposed to the same disease. But by trying to understand the factors that drive the differential in progression between people, we might end up with treatments that are truly targeted and specific to some groups of patients, and therefore more efficient. So that's the first type of artificial intelligence that is being developed and is presented here in several abstracts. The second type of artificial intelligence assisted methods is even more interesting, because it relies on trying to expand what the microscope can do. So the microscope, basically old invention, it's read by decades or even centuries old classifications that rely on what the human eye can see under the microscope with the help of some stains and so on. But now we realize that if you analyze those images, you slice them and you do small pieces of those images analyzed through methodologies that are based on different image analysis modeling, but also on laser technology that can go much deeper into the cell or the environment of the cell, then you can see things happening in the tissue that are totally invisible to the human eye, to the pathologist's eye. And there's a lot of data now emerging that if you use this digital pathology, AI-assisted machine learning methodology to look simply at liver slides, you can gain enormous amount of information that otherwise it was totally ignored until now. And that information allows you, for instance, to look at someone who has a liver cancer, and by looking at those features that only the machine can see, you can determine which liver cancers are more biologically aggressive and severe, and who will progress faster, and which liver cancers are more indolent, for instance. That's one thing you can do. So therefore, you can adapt treatment, hopefully, in the future, based on the features you can see with these methods. The second thing, for instance, is to be much more precise in the way you quantify injury in the liver. And why is that important? It is important when it comes to therapies. Because in order to see a change when you give someone a drug and you want to see if the liver improved, and you're interested in demonstrating improvement in the histology, meaning in the state of the liver under the microscope, it has to be an extraordinarily powerful drug that acts very fast to see a difference with the naked eye of the pathologist. Using this methodology, you can see with much more sensitivity and precision if there are early signs of improvement. And then you can think that, well, this drug is probably very active. If I can give it for longer, maybe at a different dose, instead of discarding it and throwing it away, saying that it's not active. So it's a way to improve selection of future therapeutics and to better understand early signs in the liver of improvement or early signs of worsening. And this was not possible until artificial intelligence was added to the pathologist's tools in order to improve his diagnosis with more confidence and to see these new features. So all this makes for very exciting information and developments in the future. And I'm very happy that in our discipline, we're also at the forefront of using these new technologies.
Yeah, thank you, Vlad. I think this is really, yeah, for all of us, very, yeah, interesting and also very difficult to foresee endeavor what it really will mean and whether, you know, also in routine, whether you need a radiologist or pathologist to look at a, you know, the biopsy, or whether this can be really done by a AI approach, perhaps even more effectively. Well, of course, this has to be all seen in the clinical practice. So if you are interested more in this topic, we will have a press conference tomorrow, a kind of a media roundtable. So the EASL communication team sitting over there, I think you, they will help you, where there will be, it's tomorrow midday, with 3 leading AI specialists working in this field. So if you're interested, please reach out to Ed over there and he can give you more information. But now, again, I would like to thank the panel for their contributions and would like to ask you and to open this press conference to your questions. So please raise your hand if you have a specific question, or please type it. If yes, please.
I'm Elvira Maselli from Italy. I have 2 brief questions, both on alcohol. Does it exist a safe or a less harmful way to drink alcohol? Because the message in my country is drink moderate and during meal is safe. And this is the first question. The second question is about scientific studies in preventing alcohol preventing cardiovascular disease or breast cancer. Messages are very confused. What do you think about these studies?
Yeah, I would like to hand over these questions first, perhaps to Thomas.
Yeah, thank you for that really relevant question. I think the second one I want to answer first because it's straightforward. You said, you asked the question if alcohol to some degree is able to prevent certain types of cancer, and the answer here is clearly no. So alcohol has never been used and never been positive signals where it can prevent cancer, okay? When it comes to the question, is there a certain level of alcohol below which it might be safe? Then I think the question, the message that we had from our WHO colleague during the opening session was very clear. There is no level of alcohol that is completely safe. And while there is likely a threshold, very individual for different people, like for different individuals, where the risk of liver disease will clearly increase. We have to be very clear that ethanol per se is harming cells. So that's why there is no level where it's really without harm, so to say. And I think in this regard, it's also critical to mention that there is a background disease burden from other diseases where sometimes the effect of alcohol is hidden. And the second aspect that I want to make is that particularly in the younger population, it is harmful, and that needs to be emphasized over and over again. It's not only the obesity, it's also the drinking in the adolescents that sometimes have impact on these very early liver diseases that we see.
Yes, please.
Michael Bittel, Fatty Liver Alliance. Also for Thomas, just following up on that. Would you say then excessive ingestion of sugar can be, in some cases, as damaging as alcohol for some people?
Well, I can clearly tell you that this increase in obesity that we're seeing is related to the diet that we have, and the most important difference that we had in our diet was this increased amount of sugars that we have. And in this regard, we have to mention this high fructose syrup that is used in industrial product all over the world because it's cheap to use. And that really came in parallel with the increase in obesity and the metabolic diseases that we face. So it's just 2 main factors that I want to mention, but I mean I'm not here to compare one to the other, right? It's 2 clear factors. And I can clearly emphasize and confirm that from the Austrian and European perspective, but I'm sure there are also other people qualified here to answer that question from another perspective.
Yep. Are there related questions or others? Yeah, please. No, please go ahead.
Use the microphone, and then the people online can hear it as well.
Yeah. This is part of our health program that we want you to move, you know.
Hi, this is Ed Sussman with MedPage Today, United States. For Tetiana Deshko, at what point, after a certain area of Ukraine has been liberated, are you able to send in your health teams? And what are their, and could you elaborate a little bit on what their experience is and what they find?
So the teams that are going to the frontline areas, yes? Yeah, so we, before the war, we have been running programs for key populations, whereby we've been using mobile vans to reach out to the remote areas where there are few healthcare facilities or no healthcare facilities to do some of the kind of initial screening for HIV, for hepatitis B, C, for syphilis, and provide pre-exposure prophylaxis and do some of the kind of gynecological checkups where possible. So to do this, we employed doctors from healthcare facilities, doctors and nurses who would, together with the outreach work and with the driver, come to the area to actually support the communities in that way. Now, as the war has started, we have expanded this work from very focused interventions for key populations, focusing on the drug users, sex workers, men who have sex with men, but now actually providing these services to ordinary population who are living very close to the front line. So the team, the medical doctor, normally it is 2 doctors, 1 nurse, 1 driver, are specially equipped, wearing a bulletproof vest and the casque, who have been trained on risks associated with possible mined territories. So they come on these minivans. They normally can do EKG, they do pulse oximeters, they measure hypertension, they can provide basic medical advice, and they also deliver specialized medications if we know that there is request for these medications there. They do some kind of, mental health in a sense support as well, because very often these are the territories which are very depressed, which see a lot of shelling and do not see medical workers. So they come. Listening is one of these mental health interventions that they do. We have also started combining these vans with humanitarian aid as well, because often these are territories which require basic, some living support, or some food, some clothes, some warm clothes in the cold months. And actually this combination has worked really well, because health-seeking behavior is very low in people, and especially men. They would not want to, when we offer testing, rapid test for hepatitis C, he would rather say no. But if he is coming for a humanitarian aid to get some things which are necessary for the home, while he's standing in the queue, there is time to persuade the person a little bit and really kind of motivate him to seek for medical advice as well. So this is the situation is very dynamic. We started with some of the territories in the east, Kharkiv region, and also in the south, Kherson region. Now we're also doing this work in Zaporizhia region. We could do actually much more. We are lacking this. We have just several vans that can do this work. We are actively fundraising for more. We were able to find them, but unfortunately that's a massive territory that has been kind of occupied and is becoming largely deoccupied, thankfully. So a lot of work to be done there.
Yes, thank you, Tetiana. So are there any other questions from, yes, please, over there.
Roger Green, Surfing National Tsunami Podcast, to Professor Ratziu. The first use of AI that you talked about, the ability to go into data sets and figure out patients that are at risk, has the potential, where the data exists, to dramatically reduce the cost of frontline screening in fatty liver, obviously, and other conditions. How many countries in the world right now do you believe have adequate data resources to do that kind of work? And what steps can be taken to help other countries make their data resources more complete for those purposes?
Oh, that's a hell of a question, Roger. It is a hard question. Screening in the general screening in general is a complicated story because it has to be easy enough to perform, cheap enough to do, and you shouldn't need tremendous resources to do it. Otherwise, it won't be available everywhere. So it is a difficult question. I think those artificial intelligence programs in the version we're now talking about, which is data mining and trying to find clusters and patterns, necessitate a huge amount of data, and the more sophisticated the data, the better the output that derives from it, the better the result, the better the prediction. Having a large amount of very sophisticated data is not, in my view, compatible with screening. So either we're able to achieve something with simple clinical anthropometric data. I doubt that this will make a tremendous difference from existing tools, but if it is the case, then yes, it could be very easily implemented. You measure simple things that a general practitioner visit, you put that in the machine, it's giving you some sort of result that stratifies the risk, and then you go on from there. I'm not sure that that would be such a high incremental gain over what we already have. So I think that for screening, what would be more interesting is, first of all, awareness about who is at risk and who should be screened. And second, try to streamline the pathways of care so that you ask each individual physician or actor in his own practice place to do the right things that he can do. And you can't overwhelm people with very complicated things. You can't overwhelm the general practitioner with doing a FibroScan, right? So you have to imagine the right tools so that at each step they can be reasonably done. And I think that will solve, to a larger extent, screening. I don't know more specifically how AI could help to that, but for sure, AI could help in doing the studies that will validate those biomarkers, simple biomarkers for whatever, and try to better understand how they can be used. But I think it can only be useful at that step. Now, you can be proven wrong. One year from now, things are changing so fast.
So there's a comment from Thomas, and I think then the question over there, right? And then we come to you.
I mean, this is absolutely right. When it comes to screening, it's a little bit different than the approach that were shown here. But one thing that we not yet use but could be useful is, for example, as simple things as photographs of the face. And I mean, give you two examples. When you have a patient with very severe liver disease, they're sometimes sarcopenic. You see them from that, and there could be things like some jaundiced eyes, like sclerosis of the eyes, which you can potentially see by artificial intelligence. And there are likely way more features that we're not able to get. But using AI in these simple daily things that are anyway done, taking pictures of people, in knowing also that there's issues with data protection and so on, could also help here in the screenings. But it must be simple, as said.
Yeah, there was a from you. Yeah, please, could you go to the microphone that all can listen to you?
I am a journalist from Pavilion House Today in the UK, and my question was actually also related to screening. So I was kind of wondering what the main barriers were to the screening process. Obviously, if liver disease is one of the most growing chronic diseases in the UK, why don't we have screening programs worldwide like we do for cancer? And then linked to that, is there something that GPs and other healthcare professionals could do to spot liver disease earlier while we're waiting for these screening programs?
Yeah, very important. Perhaps, Jose, if you would like to answer it also, and perhaps also to mention the issue of data protection or whether it's a...
Oh yeah, that's for sure. But and it's true, we have in all the countries several national screenings, colon cancer, breast cancer. And well, maybe it's a good idea to have it for the liver cancer as well. But I think first we have to, to make clear to our governments and to our national health services that it's really needed to do that. And the point is also, what do you do with the diagnosis? If you have a fatty liver, what then? And then there is a lot to do, but I think first you have to establish really the programs to help people. So I think, well, I believe the first step is really awareness of people, because people are not aware of liver disease. I hear really the most horrible stories about somebody who can't be treated for cancer because she needed a test before for her liver, or she could have the treatment. And she couldn't because her liver tests were horrible, and she can't start a treatment for breast cancer. Stories like that makes that we need more and more awareness, but I think national screening is wonderful, but that's always also a financial issue. And we need to know, what do you do if you have that diagnosed or not diagnosed? Are you safe when your liver is fine? Maybe we don't know, and things like that. So it's so complicated to set up a whole screening, and because first you need a program what to do if, and there is a big lack. And as far as even general practitioners don't know about it, there's a long way to go. And I really notice now that not only general practitioners are the problem, but also other specialisms.
Yeah, and I would like to add, because this is exactly what we are also asking ourselves, because it could be quite easy. But of course, if you have an early diagnosis or so, then it must be also something, and this should be also rooted in some research project. And if you are interested in, and this is really a global initiative, really to tackle these issues, it's called the Healthy Liver, Healthy Lives. And tomorrow there will be a paper published, and we can send you the link. It will be open access about the research priorities, exactly what Jose mentioned, in the field globally that needs to be fulfilled, that we can advance, and that we need to stay together. And we had in the opening ceremony the WHO director of EU region, but also liaised with those being involved in WHO globally. We need these stakeholders, that say, well, this is a health care issue, and then the national societies can start implement, and we from the scientific field together with the patient advocacy groups, and so they can then help how to implement it best.
I think we have an extra challenge different than from the breast cancer screening. Most people are not ill. They say, well, I'm healthy, I have my life, I'm not sick, so why should I? And so what's the problem? Somebody really said, but what's the problem then? So, well, because you are on risk, but you don't want to threaten people, but you want to realize them. But so that's the problem with a lot of liver diseases, that people, well, are diagnosed and they think that day one that they had a disease, but probably they had it for years. And when the problem starts, then you are far too late. But that's the problem, I think. But then I have to look to the physicians. That's in the liver anyway, a problem. But fatty liver doesn't mean that you are ill, and people want to be ill to take some actions. That's a human quality well, it's not a quality, but that's so human we have. So I'm fine. So we will see in the future, somebody said that to me.
Yeah. We're nearly coming to the end of this press conference, but we have an additional question over there, please.
Michael Bittel, Fatty Liver Alliance. Yeah. A question for Vlad and also for Jose. We talked, Vlad presented a lot about liver health assessment and the advantages of AI. What about the advantages for patient education? That's coming up a lot more too. Maybe you could both comment on how great that could be as well.
Patient education, that's so important. But people don't take education if they are not aware that they have a disease. That's the main problem. So then you're talking about national programs, and really, if I'm from the Netherlands, if the Dutch government will say, well, let's go for it, well, I'm the first one who's there to sit down and make the program. But there is really more awareness, more education needed about liver, and I think that, and maybe then we come back to the end of to the start. To start with education with the children, just in a normal situation, learn about your liver, because that's where it starts.
Yeah, so as I said earlier, AI is an umbrella term, very wide term. What you're referring to is probably things that can be improved in terms of awareness of the patient himself about his disease by using, digital methods, connected devices, stuff like that. So on their smartphone, they can have a lot of indications about the current status of how much they moved today, how many stairs they climbed, how they've eaten, and in general things about information about the liver. I think in that sense, digital medicine could help the patient.
I'm thinking too, I was really referring to the simplified communication with AI, even better than physicians are able to communicate sometimes, right?
Oh, that's true.
Okay, is there any final question you want to ask? Yeah, please, over to you.
Hi, Giedre Pesecita from Euractiv. So I have two questions. One is on alcohol labeling. So like we have cigarette labeling, where we know the harmfulness. What's your opinion on having labels of harmfulness of alcohol on wine bottles, et cetera, And the other question probably will go to Thomas about you were saying that you're targeting communities that, for example, inject drugs. So I would like to know how those communities are being targeted. And also it goes to the last question where there was discussion, that once you get diagnosis, what do you do about it later? So how can we ensure, or how can the treatment be ensured for these communities in the future?
I think Thomas, you can answer perhaps all the three questions, right?
The drug label, the label on the wine bottles, I think that should go to a French specialist. But I want to comment on the risk groups. Yes, I have mentioned the PIVIT, so the the persons who inject drugs, and here it's clear that this is the risk group of patients for hepatitis C, because that's the way it is transmitted. And here the question from you was how we can make sure that these people also get the treatment. I think this is one of the prototype examples of it's so easy to test, because you have one PCR result that's positive, and then you give a treatment. And in the past we had to look for different genotypes and liver disease stages. Nowadays it's like almost one pill for all. It's called pan-genotypic, so we can tackle all of them. But the question is the price. And at least for Austria, we can say that there is a national reimbursement, so all the people are within the healthcare system and are insured. And as soon as you have the diagnosis, you can actually treat them. There are two examples, and one is these people who are incarcerated in prison. They are not in the healthcare system yet, but there are also national programs that are happily supported also by industry. So we actually getting to that. We're not fully there, but we're getting there. And it's the homeless people who are not, kind of not registered, not insured, but also here with the help of industry, we are getting there. So I think for the viral hepatitis, we are there. When it comes to these more rare diseases and autoimmune diseases, yes, we have to think more. It's really complex, but at the same time, we also need awareness here. And to the label, I would say, I would be in favor of having a warning label on alcohol bottles, but please, Vlad, also your perspective.
So my perspective might not be the official EASL position, but I think we have to be very careful with a certain number of things. First of all, alcohol is in many places perceived as food, wine, not the mojito, tequila, special type of things, fancy cocktails, but just wine is perceived as food, and it's an historical food that has been on for thousands of years. So you have to be very careful. And then there's a lot of variability. Some people can drink a lot, not have anything. Others can have severe liver disease with just a few drinks per day. So you have to take all that into consideration. The second point is that once you finished half the bottle, it becomes very hard to read the fine print where it says it damages your liver. So that also needs to be taken into consideration. Now, I think it is important to have some very simple messages for the general public. There is a threshold for harmful drinking, okay? And people should be aware of that threshold, and you can place it very low, but you shouldn't place it at 0 because that's not gonna work. So harmful drinking is more than maybe 2 drinks, 2 or 3 drinks a day, depending on the condition, in general, if you're healthy. That's first message, so don't go beyond. Second message, binge drinking is dangerous. So if you don't drink at all, but you only drink on the weekends, and you go on by drinking 6, 7 drinks, that can be dangerous. Binge drinking is dangerous. Third thing, the level of harmful drinking can be lower for patients who have already a liver condition. So if they have fatty liver because of overweight or diabetes, you have to be extra careful about the alcohol you're taking. It doesn't mean don't drink at all, but you have to be very careful about that, and maybe the threshold will be lower. And the fourth important message is that once you have cirrhosis, then the threshold should be 0. So once you communicate that to people, I think you should then also allow for a little bit of leeway for those to enjoy good wine from wherever it comes, the New World or the Old World.
Thanks a lot. And I think with this, I would like to conclude the press conference. And thank you very much for your attendance here and for, hopefully distributing some of these knowledge gained and the important messages you got. If you are interested in any further communication interviews or so, please reach out to Ed from the EASL communication team, and we try to find a way that your specific answers can be addressed. So with this, I wish you a great day. I thank our faculty a lot for being here and sharing their views, and have a good day. Thanks a lot, and bye-bye. See you.